On massive blood transfusion protocol. And to chair the session, I would request Dr. Amardeep Pathak, who's consultant and in charge, Department of Transfusion Medicine at Rajiv Gandhi Cancer Institute. Dr. Pathak, welcome. I would also request Dr. Nupur Gupta, who's consultant critical care medicine at Artemis Hospital. She has authored several chapters in critical care books and avid clinician and academician. Her special interest is in critical care nephrology, mechanical ventilation, and POCUS. Welcome, ma'am.
Good afternoon, everyone. For this session on massive transfusion protocols, I would request Dr. YP Singh, who is the Principal Director and HOD at Department of Critical Care Medicine, Max Parperganj Hospital, and Vishali as well. He is FCCM, FICCM, and a General Secretary at ICCM from 2023 to 2024. He's also the Organizing Secretary of Critical Care to 2024, which is being conducted in Kolkata. His special interests include infection control, antibiotic stewardship, nutrition, and ECMO. I've had the privilege to work under Sir for a few years, and it has been an honor to work under him. Welcome, sir.
Thank you for a kind introduction. Good morning, everyone. So my talk is all about the massive transfusion protocol. I made it a very colorful, so at least it will have some kind of the impact. And as we know that more and more senses you involve, more and more it will go into your deeper memory. This is my hospital where I'm working, East Wing, West Wing. This is the ICU. So what are the objective of my talk? I think this is nothing new I'm discussing. Am I audible? Yes. So we all are practicing since our MBBS or during our internship when we are posted in a hospital in a different departments regarding. So massive blood transfusion, these are the objectives as you are seeing. We have to look into the terminology, describe the indication, consideration, review, and to summarize the talk. Now some overview of the MTP, massive blood transfusion protocol. So remember one thing, massive blood transfusion protocol is nothing but it's basically some kind of a management of the shock. And as we know that shock is basically having the two component, desoxygenation as well as the tissue hypoperfusion. These two components constitute the shock. Or not necessarily you are having a hypotension to be associated to label a patient is having a shock. A patient can be normotensive but still patient is in a state of shock. What I am going to discuss as a critical care perspective is a hypovolemic hemorrhagic shock. Right. So MTP was designed and validated primarily for the management of the trauma. Predominantly, this protocol was being basically formed for a hypovolemic hemorrhagic shock secondary to the trauma. And most hospitals are having these MTP protocols. In practice, the most common use of the MTP are for the non-trauma applications nowadays. So this MTP or this massive blood transfusion protocol is being used now for the different reason. Initially it was for the trauma, but now for any reason, most of the time it's an operative patient, obstetrical hemorrhage, operative bleeding, GI bleeding, sometimes in a medical ICUs. We do encounter these kind of a situation where we have to announce the MTP in our hospital protocol. So basically it's remain unclear whether the MTP are perfectly designed to deal with these situations, but mostly all the hospitals which is having a transfusion medicine or blood bank, they have this protocol well in place. So coming to the terminology, first is the massive transfusion. What does it mean? It means that it's basically if the patient is receiving 10 units of the PRVC per 24 hours, or to begin with, if the patient is received in an intraoperative, if the patient is received 4 to 5 units within 4 hours, that's an early indication that your patient is heading towards needs a massive transfusion. Ultramassive transfusion, when the patient has received more than 20 units of the PRVC within 48 hours, then you have to label it as a ultramassive transfusion. And the massive transfusion protocol is basically based on that. When your patient is heading towards the hemorrhagic shock, you did early detection in an OT or in any situation, whether you are a patient in an ICU. And when I'm saying the heading towards the hemorrhagic shock, as we already read about, that hemorrhage is having 4 stages, grade 1, grade 2, grade 3, and grade 4. So grade 3 and 4 means your blood loss is in the tune of 30 to 40%. Grade 4 more than 40%. So up to 30% of the blood volume loss can be managed with the combination of the crystalloid and the colloid. But beyond 30, you have to use the blood products. So grade 3 and grade 4 basically, so it means and early you are detecting that and you are doing your interventions in an intraoperative or maybe in an ICU where we're facing this kind of situation. So as we know that massive transfusion is traditionally defined again is a 10 units of the packed RBCs within 24 hours or more than one blood volume in 24 hours, or it's in adult more than 50% of the blood volume in 4 hours. Because if we take the 70 ml per kilogram is the circulating volume of the person, 70 kilogram roughly comes to the 5 liter. And in pediatric patient, it's more than 40, and in an infant, as we know, that circulating volume is 80 ml per kilogram. What is the goal basically? The goal is to massive transfusion is to limit the complication and to limit the critical hypoperfusion and maintenance of the homeostasis. Early you will do it, better it will be for the patient, and you have to be aggressive. Remember one thing, whatever type of the shock you are managing, only 4 types of the shocks we basically encounter. One is your hypovolemic, which I said, hemorrhagic, non-hemorrhagic, obstructive shock, cardiogenic shock, and distributive shock. All shocks, only 4 types of the shocks, and this we are talking about the hypovolemic hemorrhagic shock. So early you have to, for management of any shock, you have to be more aggressive. You have to be on the side of the patient. And again, I mentioned the 2 elements you have to look after, you have to correct. When you say my patient is out of the shock, desoxynation and the hypoperfusion. And it will be achieved by early recognition. When you are doing the early recognition, for example, your surgery is going on, suddenly you have noticed that my vitals are dropping down, heart rate is dropping down to 90, less than 90 or less than, a blood pressure, systolic 90 and less than 90, heart rate is going 120 and above. These are the time where you need to look into that part and also looking into the surgical field. You found that my patient is lost a good amount of the blood, is still, surgeon is, and we work in a sync. So that gives you a fair idea on that. And looking at the ABG, it gives you an idea about the tissue perfusion. And leave aside the ABG, look at the clinical parameters of the hypoperfusion. Temperature, urine output, the most, an important indicator of your, looking at your hypoperfusion parts. So now coming to that, you can achieve that by arrest of the bleeding in combination with the use of the early surgical and radiological interventions and judicious use of the blood component therapy to correct the coagulopathies. What is the concept of the MTP? The patient with a severe hemorrhage may develop a refractory hemorrhage. That's the worst of the, a nightmare for any person who is managing these patients, whether in a medical patients or a surgical patients. It's because of the dilution of the clotting factors we all know, including the platelet and fibrinogen, hypothermia, hypocalcemia-induced coagulopathy, and acidosis. Remember one thing, that acidosis and the hypoxia is the 2 triggering factors for any DIC event to happen in any patient, irrespective of the pathology at the cellular level. So the massive transfusion protocol involves the use of balanced transfusion, including PRBC clotting factors, in effort to avoid the dilution coagulopathy, which leads into a refractory hemorrhages. And as I said, it's a hypovolemic. MTP is basically a part of the hypovolemic hemorrhagic shock, management of the hemorrhagic shock. So intraoperative or postoperative hemorrhages, surgery is the most common use. These are some of the indications: trauma, GI bleed, and obstetrical catastrophes, which we face in maybe in a postpartum period or intrapartum or in a operative field. So incidence of the massive transfusion is relatively low, but the patient requires a massive transfusion, have a high mortality. One has to be very aggressive in management and keeping a close watch when managed. And when to initiate this protocol. This is the list. When the patient is unstable, as I mentioned, keep a watch on a hemorrhagic. As I said, grade 3 and grade 4 is basically needs of blood products. When the 30% and more than 30% of the blood loss is there, keep a watch on the pulse rate, keep a watch on the blood pressure, keep a watch on the field, and also when the bleeding is not being controlled or hemostasis is not being able to control, then you have to initiate the protocol, MTP protocol. What are the facts? The hemoglobin level takes hours to fall after the bleeding. So don't be rely solely only on the hemoglobin, it's all the other clinical parameters which you have to look into before you take this call. Second, that hypotension is a little, a late kind of an event, because body try to compensate by doing your peripheral, redirection of your fluid from the periphery to the centers, and it takes its own time. So when you are intraoperatively, if you are dealing such situation, you have to be you have to be into the sync with the surgeon, into the field, and looking at all those parameters, and then you take your call. Coagulation labs, for example, you said some PTIN, and by the time they will come, the things are already, the tests are already not going to give you any help. So blood products administered empirically, what protocol we follow, with ratio we follow 1:1:1 for PRBC, FFP and platelet. I think everyone who is sitting in this hall, they are doing this practice day in and out. And nothing new I am discussing on that. Considerations, what considerations you have to see. I just made it a more of a didactic lecture. Yes, very simple and plain, you know. It's you have to have an intravenous access. If your patient is in a shock, you have to whiteboard, cannula. Leave those accesses, whatever you think. But central line is not meant for a rapid, giving the fluid. We all know that. You have to have whiteboard kind of a venous accesses where you can transfuse blood very quickly. Blood products, 1:1:2 ratio, we already discussed. Volume, status and tissue oxygenation, keep a watch on that, but through your different clinical parameter as well as by the looking at the lactate values. Fibrinogen supplementation, tranexamic acid, management of the bleeding and coagulation abnormalities, calcium, acid-base imbalance and avoidance of the hypothermia. That is the most important part. These are the different, just diagrammatic. I'm not going to that detail. We all are practicing that. So, blood product 1:1:1 ratio. That's a cornerstone in the MTP. And when we say that it's a PRBC, platelet and FFP we are talking about. Most hospitals should have a protocol in place, and I think everyone is having. Everywhere where the blood bank is, transfusion medicine is there. They have their MTP protocol in a hospital. More or less the components are the same. There might be a little bit of a variability, but by and large they are on the same level. So current evidence generally supports the 1:1:1 ratio, which is used in the most massive transfusion protocols. Just took just an example in an obstetrical transfusion protocol in an obstetrician, and most of the places in the US also, how they follow. You initiated, you found that my patient needs more blood products, so you will initiate a MTP protocol or massive blood transfusion protocol in a hospital. You will send a sample to the blood bank. They will do and they will release the first batch of the 6 unit of PRVC, FFP and platelet. And the cryo, which we are not using very routinely nowadays, we use only these 3 in our hospital. But cryo definitely, when we need a patient is bleeding more, then cryo should be used because it's a concentrate of a fibrinogen. So this first batch is released. Thereafter, second batch is released, and protocol is in a place. Work is going. Blood bank is released. Third, when you have to use the tranexamic acid, 1 gram IV, and rest of the 1 gram you have to give over the 24 hour every 8 hourly. And the fourth batch. So one has to make sure that once you achieve your hemostasis, once you achieve your blood circulation or parameters are well within your range, then you have to give the announcement, you have to stop the massive blood transfusion protocol and inform the blood bank. So they, at least if you are not informing, they are keep on working on the same line. So moving forward, regarding the volume status and the tissue oxygenation, the objective is to expand the intravascular volume and maintain the oxygen delivery to the tissue. As I said, we are just indirectly discussing about the management of the shock. That's all. So concern about the crystalloid employing using the massive transfusion to maintain the blood pressure and tissue perfusion. Remember one thing, volume of the crystalloid is 3 times of the volume of the blood if you are doing the resuscitation. As I mentioned, if your blood volume lost up to 30% of the circulating volume, you need to include your blood components. Colloids can be in an equal volume to the volume lost in a blood lost. So if you are using too much of the crystalloid in the management of the patient initially, or you are waiting for till your blood products are coming to your patients and patient is bleeding heavily, what it will do is that it will dilute your coagulation factors and erythrocyte, and it will also erythrocyte concentration may eventually promote the volume overload. For example, you are giving too much of the PRVC while not giving the other parameters. So you have to make a combination, and I think the people who are working in a perioperative care, they know this because it's a part of their training. Most of the anesthesiologists or the surgeons, it's a part of their virtue of their training. They learn about the different combination of the fluid therapy in this patient and the use of the blood products in a different situation. So whenever feasible, the hemorrhagic shock resuscitation should be performed with the blood products. When your volume lost, again, third I am repeating, the more than 30% of the total circulating. Now coming to the fibrinogen supplementation. Fibrinogen is basically present in an FFP, but not in that concentration which is present in a cryoprecipitate. So as we know that if you wish to give a more fibrinogen, each cryoprecipitate, 1 unit is having a 150 to 400 milligram of the fibrinogen per unit. So guidelines suggest the target fibrinogen level of more than 150 to 200. And it may be best to repeat this early rather than waiting for the levels to drop. So 1:1:1 ratio has to be excluded from the first step. Don't wait for a levels to drop down, then you are doing the intervention. Maybe by that time you are already late. And as I said, this is the fact that cryoprecipitate has a high concentration of the von Willebrand factor 8 and 10 units is supposed to increase your level by 75 milligram, approximately 75 milligram per deciliter. Role of the tranexamic acid, as I mentioned, in that obstetrical hemorrhage, and it's having only two indications predominantly. Tranexamic acid to be used only in these two situations, obstetrical hemorrhage and the early trauma bleeding. But we are also using on a compassionate ground in a those indications where the chances of having a more thromboembolic events are very high. So one has to be a bit cautious. You have to make a balance between the two, that when your patient in an ICU is having a drop in a hemoglobin very quickly, then because these trials, as I mentioned, the whole IT trial saying that thromboembolic events are also being associated with these subset of these agents we are using in ICU. So approximately 50 to 60% of institutions include the tranexamic acid in their MTP protocol, which I already mentioned in that diagram. So as I mentioned, the 1 gram IV to be given immediately, followed by 1 gram IV over 8 hours, and it has to continue for first 24 hours. Keep a watch on that, and also be watchful clinically on the thromboembolic events of these drugs as a side effect. Now coming to the reversal of the coagulopathies, if for example a patient is already having a NOACs, novel oral anticoagulants, or on a warfarin, and coming to the ICU and having the same problem, then MTP protocol is designed to avoid the causing the dilution coagulopathy, but it won't correct the pre-existing coagulopathy. You have to take those factors into the consideration when you are managing these patients. So warfarin or NOACs requires the immediate reversal. For example, you can use the PCC, a prothrombin complex concentrate. A platelet dysfunction commonly caused by antiplatelet agent or uremia in a CKD patients coming with the bleeding, sudden drop in a hemoglobin. Obviously, desmopressin has its role because of your quality issue of the platelets. And this is the very quick list. I'm not going to that detail. It's a pure pharmacology. Warfarin, dabigatran, dabigatran. PCC is the one which has to be used if at all a patient can afford, because cost is the one factor which is coming away of using the PCC. It's a bit costly. If you can use, then definitely it's a better. No problem, I'm going to finish well within time. Calcium levels, keep a watch because of the citrate in a blood, cause the chelation and cause the hypocalcemia. And the calcium is one of your coagulation factor which can interfere with your clotting. Use 1 to 2 grams of calcium chloride if you are having a central line, but if you are having a peripheral line, go with the gluconate, and the dose is 1:3. Means if you are using the chloride 1 ampule, it's a 3 ampule for the gluconate. Right. Acid-base balance, as I said, it has to be corrected very aggressively. So patient with acidotic even before the transfusion begins, the prolonged state of the hyperperfusion leads to the acidosis, and these two factors are basically one of the trigger for your DIC, irrespective of your etiology. So correct that, bring your pH above the 7.2 very quickly, and be aggressive on that. Any pH less than 7.2 is not basically, you cannot sustain the life. You will have a depression of the cardiovascular as well as your central nervous system. And look at this, even your pH is 7.2 is still, your clotting factor effect is go down by 50%. Hypothermia, avoid it, because it's going to interfere with your conduction defect, with your arrhythmia, and also going to interfere with your clotting factors, or your hemorrhage part going to add into that. Targets, what are the targets? Again, it's when you will stop this, your mean arterial pressure 60-65, hemoglobin 7 to 9 gram, INR 1.5, fibrinogen 150 to 200, platelet more than 1 lakh, PS 7.35 to 7.45, core temperature 35. These are the criteria where you have to give your call. You have to stop the MTP. Complication, this is the list. Quickly. Metabolic alkalosis, hypocalcemia, hypothermia, hyperkalemia, transfusion-related TRALI or TACO. So, we have to be careful, keep a watch on this. To summarize my talk, it's a massive transfusion is an important life-saving intervention for patients with massive acute blood loss. One has to be careful, look into the complication, and right from the beginning, don't wait for those refractory part to be setting in, be aggressive, and this rule is applied for all subsets of the shock, including your hemorrhagic shock. Thank you very much.
I'm audible?
Yes.
This is the clinical side.
Ajay mentioned that MTP was initially being made for trauma patients, but nowadays it is being used in our own trauma conditions also.
Requirement.
As we all know that if your blood is stored, so one thing which is going to within 24 hours your platelet count drop down to 1%. Acidosis path goes up, calcium comes down, potassium goes up. 2,6 DPGs basically also get, and most important part, your oxygen dissociation curve goes to the left side. It means oxygen is more now attached to the your hemoglobin is not being released at the certain level. So oxygen dissociation. So stored blood you are using more. It is not going to add into your oxygen carrying capacity, but definitely it's going to bring down that. It takes its own time before it will goes up. These are some of the factors which comes in a way if you are using, and but there is no other way. You cannot have every time the fresh components to be used in these subset of patients.
The role of whole blood.
Nowadays we don't use the whole blood. It's only the component therapy, and for component therapy you need to have the sonoclot or the tag on your side if you are available. Use it. That gives you a more and true picture the which component is basically needed in that subset of patients. It's greatly helpful. Thank you.
Thank you, sir. With the point of tech coming up, I think as intensivists we all know that nowadays tech versus 1:1 is the new topic of discussion, that which is better and which one would actually be more beneficial. I would just like to add that tech with the advantages of reducing trali and taco, it limits the amount of transfusions that we do. But at the same time, it has also been reported to when the patients are bleeding massively, then somehow the duration of 30 minutes or 20 to 30 minutes that a tech takes to get reported, the dynamics change so quickly that the coagulation has been found to be changed when the TEG's reports have come, especially in patients who are bleeding profusely rather than controlled hemorrhages, for example, transplant and all. So I think this is one aspect which we as intensivists can study more, or probably in our clinical practices we can do studies with regarding to TEG versus 1:1, which is still a controversy actually.
It's always always a point of the debate. Whenever you are using the technology, they adds into the quality, but that does not mean that it is also going to reflect on a clinically. So it's always your decision. Definitely, these devices gives you a fair idea. It adds into you that exactly which component you need. TEG and sonoclot, these are the devices. Sonoclot takes a little lesser time comparatively if you are having on the bedside, which is available. But definitely, as far as you raise, it totally depends on the person to person, and hence in critical care practice or in medicine practice, we always say that it's the patient clinical correlation, and just modify your treatment as per the patient needs, and each patient is different. So took into the consideration of all the clinical aspects and take the call accordingly.
Thank you, sir. Thank you.
Thank you.
Thank you so much, sir. May I now request our Director Anesthesia, Dr. Rajiv Chawla, to kindly felicitate the speaker of the session, Dr. YP Singh. Thank you, sir. May I now request our Senior Consultant Neurosurgery, Dr. I.C. Prem Sagar, to kindly felicitate the chairpersons, Dr. Amardeep Pathak and Dr. Nupur Gupta.